Hey y'all, it's Catherine. This is going to be a brief overview of chronic asthma. The statistics show that in the US there are approximately 22 million Americans with asthma, and of those, about 6 million are children. Asthma is a chronic inflammatory disease of the airways. There are three major components, including underlying inflammation, airflow obstruction, and bronchial hyperresponsiveness. It is the interaction and severity of these three that play a role in the clinical manifestations of asthma. The first is inflammation. Some patients have underlying inflammation which can predispose them to exacerbations. Also, there can be chronic inflammation that can lead to airway remodeling. The second is obstruction. Symptoms of asthma are largely in part secondary to airway obstruction. As seen in the picture, airway smooth muscle bands can contract, thus leading to constriction. Additionally, inflammatory mediators may be released or mucus hypersecretion can build up and cause further obstruction. The third is hyperresponsiveness. The inflammation in the airway is thought to be a cause of bronchial hyperresponsiveness. This can be due to a number of different stimuli or triggers. Causes. When taking into consideration the causes of asthma, there are two main groups: host factors and environmental factors. Host factors take into account genetics. For example, if there is a family history of asthma, a person may be more likely to develop asthma, or if there's a predisposition to develop IgE antibodies to variant allergens. The second is environmental factors or exposures. This can include allergens as well as viral respiratory infections. Research also acknowledges that triggers or airway irritants such as tobacco smoke, air pollution, cold air, or occupational exposures can also lead to symptoms. Of note, some cases of asthma have an allergic component, but we're not going to focus on that in this presentation. Signs and symptoms most often reported with asthma are wheezing, chest tightness, dyspnea, and cough. Coughing associated with asthma is usually a nighttime cough or early morning cough. The physical exam in those with asthma is often normal. Some scenarios where the exam may not be normal is in an acute exacerbation where findings may include expiratory wheezing, tachypnea, or accessory muscle usage. Another scenario where the exam would be abnormal would be an asthma associated with atopic triad. The physical exam findings may include swollen nasal passages or other skin conditions like eczema. When considering diagnosing asthma, look for episodic symptoms of airflow obstruction and obstruction that is at least partially reversible. To diagnose, in addition to a good history and physical exam, lung function tests are essential. You can do spirometry to demonstrate obstruction and assess reversibility in patients greater than 5 years of age. Reversibility is determined by an increase in the FEV1 of greater than 12% from baseline after an inhaled short-acting bronchodilator, or by an increase in greater than 10% of the predicted FEV1 after inhaled short-acting bronchodilator. If spirometry is normal but asthma is still suspected, you can do a bronchoprovocation test. A positive test would indicate airway hyperresponsiveness. A negative test would rule out asthma. You can also order other studies such as a chest x-ray and EKG to exclude diagnoses. The bottom picture is depicting spirometry pre and post bronchodilator. The FEV1 or forced expiratory volume in 1 second improves post bronchodilator when the obstruction is minimized. The picture on the right shows a normal flow volume loop versus a flow volume loop with an obstructive pattern. From these plots and numbers, you can analyze the values needed for diagnosis, such as FEV1, and you can also analyze ratios such as the FEV1 over the forced vital capacity. Once diagnosis is made, we want to classify based on severity. This is an example of the classification of asthma severity chart. There are charts that correlate to different age groups. There's less than 5 years, 5 to 11 years of age, and greater than 12 years. Based on the components of severity answers, medical providers can place patients into one of 4 designated classes, which include intermittent, mild persistent, moderate persistent, and severe persistent asthma. 2 is the marker number for intermittent. Symptoms less than 2 days a week, awaken at night less than 2 times per month, and need for a short-acting beta-2 agonist less than 2 times per week for symptomatic treatment. This does not include prevention of symptoms. As you move right on the chart, in general, the symptoms are more frequent and the patient tends to be more limited by their disease. This is important because quality of life is an important factor in terms of how severe a patient's asthma is. Of note, these classifications do not mean that an exacerbation is any less severe for one group or the other. Once classified, each asthma severity correlates with a step number to start treatment at. This brings us to the treatment of asthma. Treatment. This figure is step-up therapy. We can use the classification table that we saw in the last slide to decide where to begin therapy. Each step lists the preferred treatment as well as alternative treatments to allow for some individualization. We want to use the least amount of medication or be at the lowest step as possible in order to control asthma. Well-controlled asthma mimics that of mild intermittent asthma on the classification chart. Some high points about this chart. All patients diagnosed should be prescribed with ASTHMA or rescue medication. More frequent use or need for ASTHMA indicates that they may need to step up therapy after assessing coherence and medication administration, among other things. As you step up in the sequence, there is increasing strengths of inhaled corticosteroids as well as the addition of other longer-acting controller medicines. If well controlled for at least 3 months, you can consider it a step-down therapy. Another important aspect of treatment is lifestyle modifications. Encourage patients to avoid triggers and environmental exposures. This can be things such as carpets, pet dander, dust mites, and smoke exposure. Aim for prevention of exacerbations. All asthmatics should receive a yearly flu vaccine. If there's an allergic component of the asthma, ensure that the allergies are being treated properly. Educate your patients. Make sure patients are aware that their comorbid conditions can aggravate asthma. This can be diagnoses such as GERD, OSA, or frequent URIs. If a patient is started on medication, encourage medication compliance and proper administration of medicines. Lastly, it is important for patients to be aware of symptoms early so they can get the proper treatment before a full-blown exacerbation. So there was a brief overview of chronic asthma. These are the references that I used, and the charts for the different age groups can be found in that second resource, the Guidelines for Diagnosis and Management of Asthma. Thanks for listening.